Treatment of osteoarthritis. Today we will discuss the management and the treatment of osteoarthritis. As per our musculoskeletal system block, the objectives are classify the drugs commonly used in the treatment of osteoarthritis, mention the indications, side effect, doses, toxicities of drug used in treatment of osteoarthritis, plan for the treatment of osteoarthritis, different cases and their treatment, the test required for monitoring the therapy of osteoarthritis, these are the objectives as per the requirement of our block in the pharmacology. In the previous lecture, we studied the treatment of various arthritic conditions, including rheumatoid arthritis and the gouty arthritis. Let us see the treatment of osteoarthritis. Osteoarthritis is a chronic progressive condition primarily affecting women. That causes loss of articular cartilage in the hands, knees, hips, and cervical and lumbar spine. The interplay of cellular, biochemical, and mechanical processes underlies the disease. The imbalance between cartilage maintenance and destruction increases the pathophysiology of osteoarthritis. Its incidence increases by advanced age, increase in the age, predominantly in weight-bearing joints. Osteoarthritis causes significant pain and functional disability. Joint space narrowing without joint destruction. The joint space narrowing without joint destruction on radiograph is a characteristic for the osteoarthritis. Osteophyte formation and bone rubbing against bone. Osteophyte formation and bone rubbing against bone are responsible for the pain, stiffness, and crepitus during physical examinations. The therapeutics of osteoarthritis. The risk factor of osteoarthritis includes in modifiable risk factor, obesity, and joint trauma are the common risk factor for the osteoarthritis. These two risk factors, obesity and joint trauma, are modifiable by preventing the weight gain, exercise, reduction in the weight, and precautions for breakage of the bone, breakage of the joint, and the trauma. In non-modifiable risk factor, as the name indicates, that cannot be modifiable includes advanced age, gender, as it is seen in the women most commonly, due to genetic region or joint locations, as there are the specific joints affected by the osteoarthritis. The goal of therapy in the treatment of osteoarthritis include analgesia, pain, and we can say there is the preventing the disability. So goal of therapy to provide analgesia includes support daily living activities, facilitate participation in physical or occupational therapies, facilitate participation in self-managed exercise program, minimize disability, and improve overall quality of life. These are the goal of therapies for the osteoarthritis. Non-pharmacologic therapy includes weight reduction and exercise, aerobic and strength training. This exercise improves the muscle strength and prevent falls. Pharmacological therapies of osteoarthritis includes some drugs, treatment is not required during periods when symptoms are absent or too minimal or to be bothersome to the patient, because these drugs, available drugs, are not disease modifying. The available drugs are not disease modifying. The available drugs just provide the symptomatic relief from the pain and thereby disabilities in the patients. So this drug will not modify the disease, just reduce the pain and the symptoms. Drug therapy includes acetaminophen, which is also termed as paracetamol, some topical agents in the form of the cream and ointments, non-steroidal anti-inflammatory drugs, opioids for analgesic, non-steroidal anti-inflammatory drugs for analgesic, topical analgesic, and acetaminophen is also analgesic. Intra-articular therapeutic options, duloxetine, which is an antidepressant drug, and glucosamine and chondroitin. These are the available pharmacological therapies for the treatment of osteoarthritis. The most important here, the adverse effect of non-steroidal anti-inflammatory drugs should be taken in consideration if the patient is having other comorbid conditions. Here, there is overview of pharmacologic therapy for the treatment of osteoarthritis, symptomatic pain, acetaminophen topical therapy. If there is a pain and it's symptomatic, the patient can use acetaminophen, which is considered as preferred drug in the treatment of osteoarthritis. Topical therapy, generally acetaminophen, we can say, is considered as drug of choice in the treatment of osteoarthritis. Topical therapies also include some diclofenac, which is diclofenac ointment, which is a non-steroidal anti-inflammatory drugs. If there is symptomatic pain and inflammation, then the patient need non-steroidal anti-inflammatory drugs, or we can say COX-2, specific COX-2 inhibitors. But while using these non-steroidal anti-inflammatory drugs, there may be risk of gastrointestinal ulceration and bleeding. If there is a risk of gastrointestinal ulceration and the bleeding, the patient should use celecoxib, which is specific COX-2 inhibitor, and it will prevent the ulceration and thereby bleeding. Celecoxib plus proton pump inhibitor, proton pump inhibitor, it decreases the acid secretion, or misoprostol, which is also gastrointestinal agent, and it protects the gastric mucosa, misoprostol. If the patient having the risk of gastrointestinal ulceration and bleeding, the best way to use non-selective non-steroidal anti-inflammatory drugs, it include COX-1 plus COX-2 inhibitor both, plus proton pump inhibitor to reduce the gastric acidity, ulceration, or misoprostol, which is a gastrointestinal agent to protect the gastric mucosa. Same, if the patient having cardiovascular risk or risk for gastrointestinal event, then naproxen. Naproxen is also non-steroidal anti-inflammatory drug. We cannot say naproxen is a safe in the cardiovascular risk patient. It should be used with the cautions because naproxen may produce some gastrovascular risk or thrombosis. So it should be used with the proton pump inhibitor, misoprostol, or tramadol, which is the opioid analgesic, tramadol. If the patient is having chronic kidney disease, as we know that the non-steroidal anti-inflammatory drugs generally decreases the GFR rate, and thereby it should be avoided in the patient with the chronic kidney disease. In such a patient, we can use tramadol or intra-articular injections. Tramadol, which is a opioid analgesic. And if the patient is on non-steroidal anti-inflammatory drug and reported to have subtherapeutic response, so in this case, the opioid category analgesic, that is the tramadol, which is the from the category of opioid analgesic, should be used. The first drug, acetaminophen, which is also termed as paracetamol. Acetaminophen is the first line therapy for osteoarthritis by ACR, American College of Rheumatology. Recommend acetaminophen is the first line therapy for osteoarthritis, and this acetaminophen is available as immediate release or extended release formulations for the treatment of pain and stiffness in patient with osteoarthritis or lacking signs or symptoms of inflammation. If there is a question, which one of the following is the first line therapy for the osteoarthritis in patient with osteoarthritis lacking sign or symptoms of inflammation for the treatment of pain and stiffness? Your answer should be acetaminophen. Dose 1000 milligram orally every 6 hours, up to maximum dose up to 3 gram per day, or 650 milligram every 6 hours, up to 4 times per day, and the therapy should be for 2 to 3 weeks. A dose of more than a dose of more than 4 gram per day is avoided. So we can say a dose of less than or up to 4 gram per day is recommended. If the dose is more than 4 gram, it leads to hepatotoxicity. Hepatotoxicity can occur in patient taking more than 4 gram per day of paracetamol or acetaminophen. And what is the antidote if the patient reported to have acetaminophen overdose, or we can say paracetamol overdose or toxicity? The antidote is N-acetylcysteine. N-acetylcysteine is the antidote for the treatment of acetaminophen or paracetamol toxicity or overdose. Acetaminophen is equally effective as ibuprofen and naproxen in patients with mild to moderate osteoarthritis pain. More aggressive medications like non-steroidal anti-inflammatory drugs and COX-2 are usually reserved for those patients who have failed to acetaminophen. So first line therapy should be acetaminophen. Topical agents are the next step in the planned care of osteoarthritis. In patient with progressive osteoarthritis, patients unable to tolerate oral non-steroidal anti-inflammatory drugs, patient at increased risk of adverse effect with NSAIDs because of the gastrointestinal, liver, renal, or cardiac diseases. Topical non-steroidal anti-inflammatory drugs should not be used concomitantly or simultaneously with oral non-steroidal anti-inflammatory drugs due to safety concern. It's most important. So start with the oral drug acetaminophen. If the patient with progressive not able to tolerate, then start with the next step, topical agents. But there should be the precautions. Topical non-steroidal anti-inflammatory drugs should not be used with oral NSAIDs due to safety concerns. But topical agents can be used alone or in combination with other pharmacologic therapies of osteoarthritis include capsaicin cream and diclofenac gel. Diclofenac gel is also non-steroidal anti-inflammatory drugs. Diclofenac and capsaicin cream is generally extracted from the red chilies. Let us see. Capsaicin cream, diclofenac gel, and diclofenac topical solutions. So this just difference is the formulation, gel and topical solution. Topical capsaicin cream, it is obtained from the red chili, applied to affected joint, hands or knees 3 to 4 times daily, and it is derived from hot chili peppers. As we know that hot chili is an irritant, so mechanism of action, the topical capsaicin cream act by depleting stores of substance P and thereby inhibiting the inflammatory mediators. It produces initial burning reactions. As we know, the red chili, when applied to the skin, feel like the burn. Its benefit may take up to few weeks to appear, not instant. And topical diclofenac gel should be used alone or in combination with oral acetaminophen for the treatment of osteoarthritis. So it means that that should be not in the combination of topical diclofenac gel with other oral non-steroidal anti-inflammatory drugs. We can use topical diclofenac gel with only acetaminophen, but not with other oral non-steroidal anti-inflammatory drugs, because untoward effects for topical non-steroidal anti-inflammatory drugs like diclofenac gel and oral non-steroidal anti-inflammatory drugs are the same. So it will increase the additive effect, the adverse effect by using oral non-steroidal anti-inflammatory drugs and adverse effect by using topical non-steroidal anti-inflammatory drugs are the same. So it should be avoided. But we can use with the acetaminophen. Non-steroidal anti-inflammatory drugs. Now we discussed the acetaminophen, topical formulations, and third one is non-steroidal anti-inflammatory drugs used in osteoarthritis patient with the pain and inflammation. The most important is inflammation. If there is an inflammation, then we need to use non-steroidal anti-inflammatory drugs. If there is only pain, then we use acetaminophen. All NSAIDs are equally effective, including diclofenac, piroxicam, naproxen, and celecoxib, and ibuprofen also. Non-steroidal anti-inflammatory drugs carry the risk of gastrointestinal ulceration, may increases the blood pressure, and decreases the kidney functions, as we discussed before. These non-steroidal anti-inflammatory drugs should be initiated in low doses on an as needed basis. Means if there is a pain, inflammation, then and then patient should take the drug to minimize the risk of adverse effect and increased to regular daily anti-inflammatory doses if required for symptom relief. In patient with low cardiovascular risk plus moderate to higher risk for gastrointestinal bleeding, use once daily celecoxib or another non-steroidal anti-inflammatory drugs plus proton pump inhibitor to protect the gastric mucosa, or misoprostol, as we just discussed in the review of the treatment. In patient with the higher risk for the cardiovascular disease plus moderate to higher risk for GI bleeding, tramadol or naproxen plus proton pump inhibitor or misoprostol to protect the gastric mucosa with carefully monitoring of blood pressure and the renal functions. These precautions we already discussed in the previous slides. What is the risk factor for gastrointestinal complication with non-steroidal anti-inflammatory drugs? The risk factor for gastrointestinal complication with non-steroidal anti-inflammatory drugs include if the patient age is more than 65 Yes. If the person is using non-steroidal anti-inflammatory drugs as a dose, previous gastrointestinal adverse effect, concurrent use of the steroid, concurrent oral antiplatelet agents including aspirin or clopidogrel, oral concurrent anticoagulant therapy use, plus the history of dyspepsia, peptic ulcer disease, upper gastrointestinal bleeding, GI hospitalization, and the cardiovascular risk. These are the risk factor for gastrointestinal complication with non-steroidal anti-inflammatory drugs. So care should be taken accordingly. Fourth option for the treatment of osteoarthritis is opioids. Examples are the codeine and oxycodone. If, as we know that opioids are addictive, or we can say dependent drug, addictive drug, as the codeine or opioids are addictive drug, it's not a first line. If the pain and inflammation in the osteoarthritis is not managed by the acetaminophen, topical formulations, and topical plus oral non-steroidal anti-inflammatory drugs, then and then opioids should be used. Oral or transdermal opioids or opioid in combination with acetaminophen as oxycodone control release and oxycodone plus acetaminophen are used in the treatment of osteoarthritis. Codeine and oxycodone used as needed for pain control in patient resistant to initial pharmacotherapy. Long-term use of opioids in the treatment of osteoarthritis, chronic pain should be discouraged because codeine has addictive property, addictive drug, habit forming drug, and just useful for the acute exacerbations of the pain. If there is an acute attack of the pain, then and then it should be recommended. Side effects include nausea and constipation, sedation and confusion, euphoria and addiction, including respiratory depressions. From the categories of the opioid, the next example is tramadol. The American College of Rheumatology recommends tramadol in osteoarthritis patients when non-steroidal anti-inflammatory drugs failed or contraindicated. If the patient is having cardiovascular, GIT, or chronic kidney disease problem, and if the patient used non-steroidal anti-inflammatory drugs without significant therapeutic effect, then and then the American College of Rheumatology recommends the use of tramadol in osteoarthritis patient. Mechanism of action of tramadol: binds to the mu receptor, centrally acting analgesic, and inhibits the reuptake of norepinephrine and the serotonin. So the role of these neurotransmitters, including norepinephrine and serotonin, is also important for the pain control. Adverse effects of tramadol include nausea and constipation, orthostatic hypotension, and dizziness and convulsion. If there is a nausea and constipation, so some like this, patient should use some laxatives with the use of opioids or tramadol to avoid the constipation. If there is any orthostatic hypotension, patient should use the tramadol during the evening time or night time, when or during the night time before the sleeping. Tramadol should be avoided in patients with the history of seizures or when possible drug interactions exist. Tramadol should be avoided in patients with history of seizures or when possible drug interaction exists, because tramadol may produce some convulsions. So it will synergize the effect of seizure or patient which is having the history of seizures, so should be avoided. Tramadol dose adjustment is recommended in a patient with renal dysfunction, because in the patient with the renal dysfunction, the excretion of drug is affected because tramadol is totally excreted by the kidney. Next, therapeutic options include intra-articular therapeutics option for patient with osteoarthritis. If the patient did not get significant benefits from the previous discussed therapies, then intra-articular therapeutic option is used. Useful in the patient with severe knee osteoarthritis after failure of oral or topical therapies. It is the last conservative treatment before surgical interventions for osteoarthritis of the knee. Last conservative treatment before surgical interventions. Aspiration of synovial fluid and intra-articular injections of visco supplementation of hyaluronic acid, that is sodium hyaluronate, is very important to improve the elasticity and the viscosity of synovial fluid. So there is a precautions before using these intra-articular injections. There should be the aspiration of synovial fluid, and intra-articular injection of hyaluronic acid is recommended as a viscosupplementations to improve the elasticity and viscosity of synovial fluid. Glucocorticoids as triamcinolone or methylprednisolone in combination with 1% lidocaine, which is local anesthetic, is used as they suppress the joint inflammation and pain, effective for approximately 4 to 8 weeks. Intra-articular glucocorticoids are given no more frequently than every 3 months to avoid the adverse effect. So intra-articular therapies include hyaluronic acid and plus glucocorticoids as triamcinolone or methylprednisolone in combination with local anesthetic lidocaine. These injections suppress the joint inflammation and pain. Next, therapeutics for osteoarthritis includes duloxetine. It is a selective serotonin and norepinephrine reuptake inhibitor. Duloxetine approved and reduces significant pain of the knee in the patient of osteoarthritis. Duloxetine is a selective serotonin and norepinephrine reuptake inhibitors, also used in depression therapy, and this role of the neurotransmitter in the management of pain is important to use of duloxetine in osteoarthritis. Next therapy include glucosamine and chondroitin. No general recommendations can be made for the use of glucosamine and chondroitin in the treatment of osteoarthritis. Why? Lack of clinical evidence to support their benefits in patients with osteoarthritis, and plus expensive, plus it increase the patient's daily pill burden and decrease the adherence to more prone therapies. Last therapy in the treatment of osteoarthritis includes surgical interventions. If the osteoarthritic patient is not able to get benefits from the oral and topical drugs, then surgical intervention will be the last therapy to treat the osteoarthritis. Surgical interventions include arthroscopy and the joint replacement. The indications of surgical interventions include if the patient has severe pain and not responding to medical treatment, or if the osteoarthritic patient and disability due to osteoarthritis interferes with the daily activities. Then and then, surgical interventions are recommended. So, if the patient of osteoarthritis complaining of pain, the first line of treatment is acetaminophen as per the American College of Rheumatology guideline. If the patient complaining pain and the stiffness, and if the osteoarthritic patient in home non-steroidal anti-inflammatory drugs are contraindicated, then tramadol should be useful. Thank you very much. Any questions?